Good evening, everyone. I'm Dr. Nanda Kishore. I'm a pediatric intensivist at KIMS Hospital, Hyderabad. This evening, I'm going to talk about initiation and monitoring. I have nothing to disclose. Let's start with initiation. So initiation process starts right from you get the call for ECMO. So a lot of success of ECMO depends on choosing the right patient for the right indication and initiating it at the right time. And look at what are available resources and expertise. Do you have all the people or do you need any other help? And where are you going to initiate? Are you going to initiate ECMO in ICU, emergency room, in theater, or cath lab? A lot of it depends on how sick is the patient and what are the co-interventions patient would need. And decide what mode of ECMO you're going to go on. Is it going to be respiratory support or is it going to be cardiorespiratory support? In that case, we know arterial mode of ECMO. Or is it going to be one of those hybrid modes? Once you decide on that, before you even touch the patient, take the consent from the family and prepare the part. What I mean to say is, especially if you're going on a veno-venous ECMO and we're going to cannulate the femoral vessel, expose the pelvic area and shave the pubic hair so that it'll be easy when you go on ECMO. And many times we actually realize this after scrubbing is not being prepared and we have to wait for some time for it to be prepared. So you can avoid those time delays. And to arrange for the right size of cannulas and dilators. So when you choose the cannulas of at least one or two sizes different. And usually we do it by ultrasound guidance for cannulation, especially if you're doing the percutaneous cannulation. Other mode is to do an open surgical technique where you look at the vessel size and decide the cannula. But ultrasound helps a lot in that situations. We'll come to that, how the ultrasound helps in the next slide. And once you arrange for the cannulas and dilators and open the circuit, usually what we do is the saline priming. So you run the saline through the circuit before connecting it to the patient. But sometimes you do blood priming, especially if the patient is anemic, already pre-existing anemia is there. Or in case of children, where their priming volume itself is equivalent to child's blood volume, where risk of dilutional anemia is there. So we do blood priming in those situations. And then think about what is your anticoagulation strategy. Generally, when the patient goes on ECMO, then we give 100 units per kilo of heparin bolus, 100 units per kilo of heparin bolus. When the patient is already coagulopathic and bleeding, and then we give slightly less doses. Sometimes there's the instances where we went on the patient heparin free also, but that kind of rare situations. And then determine the cannula insertion length, how far the cannula insertion you're going to put in. Generally, what we tend to do is I tend to measure from xiphisternum to inguinal ligament for a veno-venous mode ECMO, where you're going to use femoral vessel and jugular vein. For jugular vein, I usually measure from the sternal angle to the middle of the neck. And then once you put the cannulas, connect those cannulas to the circuit without air entering into it. And then one need to have a real hands-on experience for that, how to do it, which you're going to learn in hands-on sessions over the weekend. Once the patient is connected to the ECMO circuit, all this circuit is clamped so that you will not expect any flow, or there won't be any blood flow from patient into the circuit, a reverse flow. So what we tend to, once you connected everything, then you increase the revolutions per minute to 1000 RPM and then unclamp the circuit. And you usually unclamp on the venous side and then unclamp on the arterial side. Then slowly increase the flow to the required support. If it's a venous mode ECMO, one would need anywhere between 80 ml to 120 ml per kilo per minute. Usually, the neonate or small children, higher the flow. So usually with neonates, we go to 120 ml per kilo per minute. In adults, we go to 80 ml per kilo per minute. That is to begin with. And then depending on the requirement, and then you adjust the flows. Similarly, for veno-arterial mode of ECMO, we go for 3 liters per meter square per minute of cardiac output. So which would roughly translate into 100 ml per kilo per minute in neonates and infants, and 60 to 80 ml per kilo in children and adults. Then as you increase the flows, you increase the sweep gas to match it. Usually what we do is 1:1. So what it means is if you increase the flows to 1 liter, then you increase sweep gas to 1 liter. If you increase the flows to 2 liters, increase the sweep gas to 2 liters to match it to that. And then once the patient is stabilized, you do blood gas, and then you adjust the sweep gas according to that. So when the patient goes on ECMO and stabilizes, he would not need a high pressure ventilation. So you usually back up from the ventilator to the minimal settings. Aim is to keep the lungs open at the same time. You're not causing much injury to the lungs. Similarly, we need to come down on inotropes as well. As per the requirement, go by the hemodynamics. If it's a venous mode of ECMO, generally we should be able to come off all the inotropes, because usually that inotrope requirement, because of hypoxemia, and then once you correct hypoxemia, inotrope requirement should go down. In a veno-arterial mode of ECMO, where you've initiated ECMO for the weak heart, poor heart function, then you might need some amount of inotropy for the heart to function. But we probably may need to come off vasopressors, but leave some amount of inotropy in the background. So once you got the adequate flows and patient stabilizes, you confirm the cannula position. Usually what we tend to do is at the bedside echo, by transthoracic echo, looking at the cannula position and secure the cannulas. And then later on we get X-rays to confirm the cannula position. So this is what I meant by ultrasound guidance for the cannulation. What we tend to do is we measure the vessel size on the ultrasound. Then that kind of gives a rough diameter of the vessel. That'll give us some idea what kind of cannula I can choose. Usually cannulas, everyone need mention what is outer diameter of the cannula on the mark. It usually says what is the diameter of the cannula as well. So that kind of helps us to choose the right size of the cannula. So this is a guide wire which we use, usually 150 to 200 centimeters. Stiff guide wire, we use it with J-tip. And then you get two kind of cannulas. Return cannulas is a smaller one with a single opening at the end. And the drainage cannulas, which are longer and with multiple holes. Generally, in a typical adult, say, example of 70 kilo patient who is going on ECMO for ARDS, they typically go off a drainage cannula of 25 to 27 French drainage cannula, with the return being anywhere between 22 to 21 return cannulas. So usually return cannulas are slightly smaller than the drainage cannula in terms of length and in terms of diameter. Now coming into dilators, if you get a dilators along with the cannulas, that's a good. You can use those ones, but many times it's not possible and they're quite costly as well. So this is the kind of, we found it a good alternative which is less expensive. So these are the urethral dilators. So we take a sterile urethral dilators and use it. It comes in a different sizes and quite useful to dilate the vessels and at the same time cost effective as well. So this is a pediatric patient went on veno-arterial mode of ECMO for viral myocarditis. So yeah, this is a drainage cannula which is put into the percutaneous method, and this is a return cannula which done by open cut down, by surgical cut down. So we put a cannulated the femoral artery. Because we cannulated the femoral artery, so we worried about the distal perfusion of that leg. So to prevent the distal perfusion problems, we put another cannula to maintain the distal perfusion. So this distal perfusion catheter again connected to the main cannula through a Y junction, which is not shown here. And this is a venous ECMO where the drainage line is in the femoral vessel, and then this cannula is fixed along the long axis of the thigh, and then we took a loop and fixed again to the thigh. And similarly, the neck cannula, we fixed along the neck and they took a loop and fixed onto the chest. So this kind of helps us to minimize the cannula movement, and whenever the patient moves, cannula also moves along with the patient. So there are some problems one need to be aware of while initiating. So because we're going to cannulate the big vessels and put a guide wire, so there's a risk of these big vessel injuries there. And if you're not careful enough, then always chance of wrong track formation is there. especially if an obese patient, if you're not able to navigate your dilator through the underneath the inguinal leg when there's a high risk of wrong track formation is there. If that is the case, then if you anticipate that, maybe better to go for a open surgical cut down and cannulating the vessel. And many times we put these guide wires and cannulas into the heart. There's a risk of heart perforation, especially right atrium. And there are instances it actually right heart was perforated and we had to cut open the chest to rescue the situation. At least for this reason, one need to surgical backup whenever you, even when the surgery is not done, we need to have a surgical backup to bail out those kind of situations. Once the patient goes on ECMO, the risk of systemic inflammatory response because of non-endothelial surface of the ECMO circuit. And then one can get into capillary leak, and you would need a lot of fluids to fill that capillary leak. If the patient is already septic and capillary leak situation, and going on ECMO may make things more worse, and you would need a lot of fluids to compensate that. If the patient is hypovolemic or intravascular hypovolemia is there, there can be chattering of the tube, which we'll show in the next video. So if the tube is a certain jerky movement of the tube is there, circuit is there, that means there's not enough volume in the patient. So we need to give more volume. We also need to be aware of certain metabolic abnormalities which can arise while going on ECMO, especially if you use the blood prime. So what we tend to do is we always do a blood gas when you're doing blood prime. So that kind of tells us what is the potassium level immediately. And usually we tend to use the as fresh blood as possible. And similarly, the patient is risk of hypocalcemia because the citrate anticoagulation in the prime blood can chelate the calcium, and patient is at risk of developing hypocalcemia. So we need to be aware of that. And if you veno-venous ECMO, when the cannulas are too close to together, the risk of recirculation is there. This is a video showing a charting of the tube. So if you can appreciate the sudden jerky movement of the tube, that means the hypovolemia is there, chattering is there, and at the same time flows are also coming down. No, that's a jerky. That's what I was talking about, not the pendulum movement. That's a jerky movement which is seen, that is chattering, and the same you can see the flows have come down even with revolutions of 3,400. And if everything going well, we should see the good color difference between the venous limb and the written limb. So deoxygenated looks dark red and oxygenated limb looks bright red. So if there's a good color difference, that means it's doing well. If the both limbs are bright red, that means a lot of recirculation is happening. If the both limbs are dark red, that means there's not enough oxygen getting into the oxygenator. This is X-ray showing the two cannulas are too close to each other, then the risk of recirculation is there. And if recirculation is there, it is two limbs to be bright red. And then you need to adjust the cannula position to see a good color difference between the return and drainage limb. Then coming to monitoring, for discussion sake, we can categorize into circuit-related monitoring and patient-related monitoring. So one needs to be familiarized with the equipment to troubleshoot. It is very essential. And one of the main aim of this workshop is so that everyone is familiar with what they're dealing with. And then when the patient goes on ECMO, what we're aiming at is adequate flow. So what we're targeting is the flows. But to get to the flows, what we change is the revolutions per minute, that is RPM. So typically what we say, if we need to increase the flows, we go up on the RPM. So that's what normally happens. But be aware that that equation is not the same always. The reason is most of these ECMO circuits are centrifugal pumps. So what it means is they're preload and afterload dependent, like a normal heart. So what it means is if the patient is hypovolemic, even for the same RPM, you may not get good flows, or you might need a higher RPM to get the flows. And sometimes you can see there can be chattering of the tube. So in those situations, you give volume and then the flows goes up with the same RPM. Similarly, if there's a obstruction or a kink in the written limb, for the same RPM flows would come down. So then we need to look for, is any obstruction there, or is the cannula hitting against any vessel wall? And then we need to address those issues rather than just going up on the RPM. And then you measure the pre-pump pressures. So that tells us how much negative pressure we need to suck the blood from the patient into the circuit. So usually we measure it, and if anything more than -30, that means too much negative pressure. If it is more than that, you can see chattering of the tube. So what it means, if the more negative pressure is there, then you would need volume to maintain an optimal zone. Similarly, we also need to measure the pre and post oxygenator pressures. And what we're interested is in the difference between the pre and post oxygenator pressure difference. There's no set number for this. Again, depends on what kind of oxygenator you use it. So different oxygenator have slightly different numbers, but again, there's no specific number for any oxygenator. What we're interested is when a patient goes on ECMO, document what is the difference between pre and post oxygenator pressure difference. That is delta pressure. So that tells us what is the pressure drop in the oxygenator, and you document that and see what happens to that over a period of time in the next few days or weeks, depending on how long the patient is. And the pressure difference is increasing. That means there's an increased resistance oxygenator, which most likely because of some clot formation in the oxygenated tubes. So if the pressure difference is too significant, that means there's a risk of oxygenator failing. So we need to identify that even before it happens. So we need to monitor that. In that way, it's pre and post oxygenator pressure. We need to measure it constantly. And then we need to check the anticoagulation status. And ACT, activated clotting time, is one of the most widely used tests at the bedside. And it gives the result instantly. And what we're aiming for is anywhere between 180 to 220. So again, depending on the what's the patient anticoagulation status. If the patient is bleeding, then you're trying to maintain slightly lesser ACTs. Or if there's a clot formation, pre-existing clots are there, or some clot formation happening over a period of time, then you tend to maintain slightly higher ACTs. But bear in mind that ACT is very good test and quite useful at bedside, but not always sensitive. So what we tend to do is we usually back it up by APTT. So we do a ACT when the patient goes on every couple of hours and the patient stabilizes, and then we do it every 6 to 8 hourly. And then we back it up by at least once or twice a day APTT. And when you do APTT, what we're aiming for is 1.5 times to twice the normal. And somebody has the facilities to do a thromboelastogram, then you can do it. And then what we find useful is the patient is bleeding, and then if you do not able to pinpoint what is the reason for bleeding, or if you want to give any blood products, then TEG is quite useful in that way. But commonly used is the ACT and APTT. And then we do a blood gas from the oxygenator once a day. So that kind of tells us efficacy of the oxygenator. So usually when the patient goes on ECMO, then we would expect oxygen PaO2 anywhere between more than 300. And generally it usually is in the 400 zone. If it is anything less than 200, is a bit of worry. So which was when a patient goes on ECMO, the PaO2, which was 300 to 400, is come down to 160 now, and say at the same time pre and post oxygenated delta pressure difference also increasing. That means that oxygenator is going to fail. So we need to act quickly. So rather than wait for it to fail completely, you preemptively anticipate that and change that oxygenator. And also look for the cannula position every shift. So once the patient goes on ECMO, document how far the cannula went into the patient body and document that. And have a transparent dressing when you put in patient, and check that cannula position every shift and document it. So that kind of tells us whether the cannula is moving or not and how far it's moved. And also similar serial X-rays also helps us to check the cannula position. And every shift we do a circuit check starting from one end to other end. Starting from either you come from the venous end or the arterial end, but one end going through all the way through the circuit to other end, mainly looking for any clot formation to check all the connectors are tight, there's no leakage, there's no air into the circuit. And one good piece of an instrument required at the bedside is a torchlight. So this should be at the bedside always. And whenever you do a circuit check on another end, we put a torch and walk it through all the way through one end to other end. Coming to patient-related monitoring, it's like any sick patient in ICU, they would need a serial monitoring of the vitals, and they would need more frequent investigation in terms of hematology, metabolic, and blood gases, because they're quite sick patients, and they would need neuro observations. And many of these patients are heavily sedated and paralyzed, and they're anticoagulated, and they're at high risk of any neurological event. So we need to monitor these neuro observations along with the vitals. So we document those things along with the vitals. And if it's a veno-arterial mode of ECMO, we need to monitor the cardiac function serially, because in veno-arterial mode of ECMO, there's a significant afterload increase to the heart, which is already compromised. So the risk of left atrial hypertension and heart dilatation might be happening. So we need to monitor that and take measures. So usually what we do is we start some kind of inotropy to increase heart contractility. And even that failing, then you need to do a left heart decompression. So that itself is some other topic, we'll deal with it. But one need to monitor for the cardiac function. And what we're looking at is whether the heart is able to decompress or not. Similarly, when you cannulate the artery, what we're looking at is the distal limb perfusion. So even though you put a cannula into the distal limb, so you want to make sure that that perfusion is enough to that leg. So, and then because this is a constant flow, not a pulsatile flow, we won't be able to feel the pulse, or neither we won't be able to get pulse oximetry on the limb. The one way to know it is clinical examination, looking at the color of the limb, capillary refill time, and temperature. And other way is to do a ultrasound to see what is the flow. So we need to monitor that, make sure that flow is adequate. And if you have a facility, sometimes we also, if a changeable flow probe is there, we put a flow probe onto the distal limb to see how much is flow going to that leg. Then many of these patients in heparin, so the risk of bleeding is there. So one need to monitor for this bleeding risk. If anything superficial, we can control it, but anything deep inside, we won't be able to know. So we need to monitor for those very closely. If it's infants, we do a serial head ultrasound where the anterior fontanelle is open. And there need to be a lot of analgesia and sedation, so we need to monitor specific monitoring for that. And we need to document all these things to see what's happening serial trends. So this is the patient, pediatric patients we put on ECMO during COVID times. He's around 1.5-year-old, went on ECMO because of COVID ARDS. So here we cannulated the carotid vessel. So we cannulated the carotid artery and vein. Because we cannulated the carotid artery, so we wanted to make sure that that half of the brain is perfused from the circular villus from the other side. So we put a NIRS monitoring to look for the cerebral saturations, and you can see the similar saturation both right and left. So that kind of reassures for us to say that even other cannulated side of the cerebrum also being perfused well. So to conclude, for successful initiation and monitoring, a lot of it goes down to how much you prepared and anticipated the problem so that you can mitigate these problems even before they arise. And going in sequence always helps, and having a checklist so that even one step is not missed out is quite useful. And team training is quite an essential part of that, because the many people are involved in the ECMO initiation, not just a doctor. They're going to be doctors, nurses, perfusionists, respiratory therapists. So we need to have a coordinated team work for that. And we need to document these trends, what's happening with the patient, as well as the ECMO circuit and the patient, what's happening with these things, and how they're correlating with each other. And, ECMO is a quite invasive mode of treatment, and a lot of complications associated with it. And when it arises, sometimes we will not have time to act upon it. So we need to have some kind of a backup plan. What if something goes wrong? Whom are we going to call? How are we going to deal with it? Especially in the middle of the night, not many people are around. And one important thing is the communication with the family. Many of these patients, when you go on ECMO, we need to prime the family that they're not going to get better in 2-3 days' time. At least they may get better in a week or two. Sometimes if it's a COVID or something real bad ARDS, it may take weeks. So we need to make the family prepared for that. Otherwise, it's going to be big trouble to deal with them later on. So, and the communication goes a long way for successful ECMO as well. So with that, I'll conclude. Thank you very much. I'm ready to take any questions if there is anyone. Thank you.